Very good evening to all. It gives me immense pleasure to welcome all of you for this scientific update. This has been a long journey. Way back, we started this Gurukul update. Initially, it was finalized that we will have only postgraduate students. And later on, yes, everybody wanted to join in. So as the saying goes that hum chalte gaye aur karawan badhta gaya. So that is how it has happened. And then it makes me more emotional today because we have the legend of the game, my professor, who I think three of us have been blessed to be taught by Dr. Agramli sir. So it is indeed a pleasure and a great moment for us. Can we have the video, Minto, please? So this is where the journey started. So I thank you for playing that video. So I again thank you all for joining. And at the outset, now let me welcome Dr. V. Srinivas. He's a senior consultant physician and head of the department, Yashoda Hospital. He's the MD of FS Endocrine and Diabetic Center, my partner, very good friend of mine. Over to you, Dr. Srinivas.
Yeah, thank you, Dr. Fares, for the warm introduction. And as of all of you know, that as a part and parts of our Frontiers Diabetic Awareness Society, we are continuing this continuous medical educations for all of our students, colleagues, junior colleagues, and today we are very happy to share the screen with our respected Professor Raghuram sir. Mintu can just share me that schedule so that I'll be welcoming that first speaker. So, as all of us know, so today we have three speakers and three sessions as a part and parcel of our Gurukul program today. And the first talk will be by Dr. Arvinda. He'll be talking on the role of Remogliflozin and its pleiotropic effects. And the second topic is on urinary tract disease management by Dr. V. Chandramohan. And third topic is by the COVID and diabetes management by Drs. Amit Gupta. So before I would like to start this CMA for today with first speaker, Dr. Arvinda. As everyone knows, he's a well-known renowned speaker, Dr. Arvinda Jagdisha, who did MD and MRCP from London and fellowships from Edinburgh and London, and immediate past president of RSD Karnataka chapter. Has a vast experience being worked in the various hospitals in UK and field of diabetes and endocrinology. One of the few who has got an MRCP London with a triple FRCP degree. Is the recipient of Bangalore's highest civilian award, Nadaprabhu Kempegowda Award 2018, winner of the Times of India Healthcare Achievers Award 2018 in the field of diabetes, now Chief Diabetologist and Chairman in his own Integrated Diabetes Care Center, Dr. Arvinda Diabetic Center, former Clinical Fellow with T. Bush General Hospital, Wales, UK, organizing Vice Chairman KRSDI Chapter Diabetes Conference, has been a speaker or chairperson in national and international levels, including Epicon and RSDI. The various publications to his credit in various index journals, organizing secretary for DISAD 2014 Diabetes Conference held in Bengaluru, received felicitations and Diabetes Vaidyaratna Award from the people of his hometown, Ravandur, Mysore district, received Diabetic Awareness Initiative Award in Diabetes India Conference, New Delhi 2017, started RP Jagdisha Foundation with the motto of conducting various social surveys. So with this introduction, I would like to invite Dr. Arvinda to deliver a lecture on the role of Remogliflozin and its pleiotropic benefits.
Okay, I'll share my slide. Are you able to see my slide?
Yes.
Yes, sir.
Okay. Thanks, Dr. Srinivas, for the nice words and nice introduction. Thank you so much. And thanks, Dr. Faraz, for inviting me to deliver this talk in this very good scientific program that is Gurukul Update. It's always a good concept which you have done, which brings in all the medical faculties as well as the postgraduate students, or the students who are interested to know about diabetes. So it's a good concept so that the awareness is spread across India, because as you all are aware, diabetes is one of the field which is being spreading like tsunami. We have to be aware of the new things happening in the field, as well as we have to do an educative process so that we can prevent the spread of diabetes. So today my topic is role of Remogliflozin and its pleiotropic benefit. So first of all, greetings from Bangalore. I hope all of you are keeping well in this tough corona pandemic. So kindly take care of yourself, your family, as well as your patients accordingly. So going to my talk, so Remogliflozin. So if you see, there are the three SGLT2 inhibitors were already there in the market since many years, like empagliflozin, canagliflozin, and dapagliflozin. Now, recent addition, I should not say recent, it's already a few years now. So, recent thing is the remogliflozin. So, remogliflozin is I should say, it is one of the blockbuster molecules at the moment in our country because of its cost factor and because of the scientific backup as well. If you see in this chart, remogliflozin, though being a recent addition to the SGLT2 inhibitor, it has enabled access to the SGLT therapy to the numerous type 2 diabetes. So you can see from May 19, that is 2019, I should say BC. I'm sure all of you are aware what is BC. BC is before Corona, AC is after Corona. We don't know when we come after Corona. Now at the moment we can talk about BC, that is before Corona. So way back in, that is last year, 2019 May, the remogliflozin came into the picture. Since then, the prescription number has been climbing. You can see the data available till February 20th, how the prescription pattern has increased across India. You can see the number of prescription. That's the red line. What is pointing out is the Remo when compared to the EMPA, DAPA, and canagliflozin. So you can see the number of thousands of prescription has increased, eventually becoming the most popular SGLT2 inhibitors prescribed in our country, basically because of the cost and the science backup. I always tell remogliflozin is one of the molecule, like it is like poor man's SGLT2 inhibitors. It's not only the cost, but it has got sufficient science backup as well. So it has been deliberated in reputed national and international forums, like in various conference. It has been dealt with about this particular molecule. Whether a conference like IDEC, Dialogues in Diabetes. Our Dr. Amit is here today to deliver his talk. He is one of the main member who organizes this Dialogues in Diabetes conference every year successfully. In that also it has been presented, and conferences like RSS Day, ACCon, CSICon, APCon, in the various national conferences, you can see 21 excuse me 21 scientific presentation in national conferences, 3 publications in international journals, 6 papers, posters in national and international conference. You can see in the bottom, it has been presented in the 79th that is ADA conference as well. So the evidence that was on remogliflozin, the robust development program conducted globally for remogliflozin till its first approval in India. Like before it came to India, the robust developmental program was planned for this particular molecule. you can see the development program the way back in 2017. You can see there are phase 1, 22 studies are there regarding the phase 1 study. Phase 2 studies, there is 3 studies involving 800 patients. Phase 3 study, that is involving 900 patients. So it has been studied extensively in before it came into the market. So early develop, you can see in this chart, early development is as per US FDA requirement, while a late development as per CDSCO guidelines. So this is the development program which is seen in Remogliflozin. Coming to this particular study, that is pivotal phase 3 Indian study, you can see the design of this study. It is a randomized controlled non-inferiority study, double-blind, double-dummy study. So you can see it has been comparator with the DAPA 10 milligrams. That gives an important data because we have to see in this particular, the comparator is Dapagliflozin. So you should see it is the only trial with head-to-head comparison with existing SGLT2 inhibitors. Sample size is 906 and study site is like 58 sites across India. It's a multi-centric trial including all zones. So Remogliflozin, it is comparable to Dapagliflozin in all glycemic parameters. That is what the pivotal study has shown. You can see on the starting from the left-hand side, at the week 24, that is at 6 months, the HbA1c compared to Dapagliflozin, the difference is like 0.72. With Dapa, it was 0.58, but with Remo, it is 0.72. At week 24, you can see the reduction of fasting blood glucose around 17 and 20 respectively. At week 24, postprandial glucose is 39 and 32 respectively. So what you can see in this chart is Remogliflozin 100 milligram was found to be non-inferior to DAPA 10 milligrams. So non-inferior, it's an important statement. So when it compared to the side effect, like most of the side effects were seen in almost in the similar incidences with regard to DAPA and Remo. It may be like a male urinary tract infection or female urinary tract infection or mycotic genital infection, or whether it requires to increase creatinine. All these were parallelly equal, means it is not extra things were not seen with Remogliflozin. It was very much comparable with the Dapagliflozin. Equivalent efficacy observed in clinical trials versus other SGLT2 inhibitors. You can see in this chart whether it has been seen with compared with Cana, Dapa, and Empagliflozin. You can see the differences in the reduction of HbA1c or the fasting glucose or the postprandial glucose, whether it may be compared to weight reduction, systolic blood pressure reduction, diastolic blood pressure reduction. It was almost comparable with all the SGLT2 inhibitors. I mean, what does this slide say is Remogliflozin is equally efficacious when it is compared to Cana, Dapa, and Empagliflozin. So evolving evidence on Remogliflozin, what are these things which is coming up in, which has come up in Indian type 2 diabetes. So Remogliflozin development further enhanced in India. So the way back in 2017, it was the first developmental program was done across. But once it is available in Indian market, there are further enhancement of studies which was done in our country. So you can see that studies like Revolution, Inspire, Remit, and Adapt. So it is a 2019-20. There was a continuing clinical development with Remogliflozin. So all studies strengthen the evidence in Indian type 2 diabetes. There are 4 clinical studies in India involving more than 11,000 subjects with 2 real world assessment forming a large database of evidence with any SGLT2 inhibitors in India. So this is an important study, that is a INSPIRE study. It's an Indian type 2 diabetes patients of Remogliflozin safety and effectiveness. It's a real world experience study, which is important. If you see the study methodology, it was the real world assessment of effectiveness and safety profile of Remogliflozin when used for management of type 2 diabetes patients. So selection criteria was all adult patients with type 2 diabetes receiving a Remogliflozin based regimen as per routine practice with 3 months follow-up completed. So you can see that initiation of Remogliflozin based regime, month 1 was followed, month 2 was followed, and 3 months was followed up. So this was the demographics, comorbidity condition, anti-diabetic treatment, concomitant medication, efficacy assessment, adverse effects, lab assessment were all done. This was the baseline demographics, what you are seeing in this chart. You can see that 5,400 odd patients were recruited in this study, and this was the demography of the patients. And you can see the comorbid condition. It's like uh, nearly 55% associated with hypertension, 46% with dyslipidemia, and 8% with CV disorders. Rest all like thyroid, diabetes complication, obesity, COPD, hyperuricemia, all this associated comorbidities were included in this study. Means it was patient were having those problem along with us. Now, another important thing is concomitant OADs. Like what were the medications patients were already on? So if you see this chart, the various groups of medications patient were on, or on to that, the Remogliflozin was added. The most common prescription of patient were already on was the metformin and sulfonylurea, that accounts for 33.8%. Then only metformin was 18%, and metformin with DPP4 inhibitor 16.8. Like that, it goes on. Like all the alpha glucosidase inhibitors, glitazones, combination with triple combination, and 4 combinations also. 4 drugs are also. All these groups of patients were seen, and over on to that, Remogliflozin was added. If you see this concomitant medication, on the left hand side, you can see the chart depicting what all the concomitant medications patient were on, and on the right hand side, you can see the medications, like what are the other medications. Like for example, it may be for cholesterol, it may be for thyroid, it may be a nutritional supplements, or all these things. Like routine pattern of treatment, what the patient used to take was there. Along with that, in this study, they added the Remogliflozin, and they have seen what is the response. The glycemic assessment was done through HbA1c, fasting plasma glucose, and postprandial glucose. Metabolic assessment was done with body weight and body mass index. Blood pressure assessment was done by assessing systolic and diastolic blood pressure measurement. You can see the glycemic parameters, what you saw, what is the result outcome in the INSPIRE study is the HbA1c reduction what seen was around 0.95% in 3 months. Fasting glucose of 42.4 milligrams per reduction was seen. Postprandial glucose of 69 milligram reduction was seen. So body weight at 3 months, 2.6 kg of weight loss was seen in 3 months. Body mass index of 1 reduction was seen in 3 months. Systolic blood pressure reduction was 3, and diastolic blood pressure was around 2.3 reduction was observed. The study results you can see here, and if you see the efficacy assessment, what they did is they did the subgroup analysis as well, subgroup analysis, and seen whether there was any good effect efficacious was seen. You can see the HbA1c, they made it into like 3 groups, like HbA1c less than 8.5, that is 48% were included, 8.5 to 10%, that is nearly 44%, and HbA1c more than 10, the 7.3% were there. On the right hand side, you can see the body mass index, all body mass index patients were recruited, like less than 25, 25 to 30, and more than 30. So based upon the subgroup, you can see the response with regard to HbA1c, fasting glucose, and postprandial glucose, and weight. So there was a good reduction in all these parameters. You can see more the HbA1c, higher the HbA1c, higher the reduction with fasting glucose, plasma glucose, and weight as well. That is what you can see in this chart. So this is what the subgroup say about the body mass index, like less than 25, 25 to 30, more than 30. So higher the body mass index, more the weight reduction was seen in this study. So coming to the safety concerns, that is the adverse events. So like we all know, with any SGLT2 inhibitors, they are prone to develop genitourinary tract infection because of the glycosuria. So they have seen like 12.5%, which is the most common side effect which was seen in this study. I'm sure our next speaker, urologist, waiting to talk about this particular urinary tract infection and its management. And next is side effect was the general side effects like acidity, body pain, bowel disturbances, giddiness, vomiting, headaches were seen with the remogliflozin in the INSPIRE. But this is all seen in all the other SGLT2 inhibitors. So coming to renal parameters, EGFR was like reduction was about 1.8. I'm sure all of you are aware that any SGLT2 inhibitors, when you start with, there will be initial decline in the EGFR, and gradually there will be improvement with the EGFR. So the rest of the things, uric acid and USER, you can see there was a reduction with uric acid as well, reduction in USER as well. So equivalent effectiveness versus other SGLT2 inhibitors, if you see the real world evidences. So when it comes to DAPA real world, that was the forefront. You can see the reduction of -1, that CANA 0.9, EMPA 0.91, INSPIRE, that is with REMO, it is 0.95. So good effectiveness, very much comparable with the other real world experience evidences with other SGLT2 inhibitors. So continuing with the clinical experience, like any experience with remogliflozin, many investigators have done studies about remogliflozin, what they have seen. So this is one study where it is called EMBRACE study, that is a real world effectiveness and tolerability of remogliflozin in uncontrolled type 2 diabetes. If you see in this study, the result what they seen was the mean HbA1c reduction of 0.94, systolic blood pressure reduction of 4, diastolic 2.2, body weight reduction was 2.8. Next, another study which was published in Endo 2020, that what is this is a switchover, like any patient who are already on SGLT2 inhibitors who are switched over to remogliflozin because of the cost constraint. So what is the result? You can see this result after switching over from the existing SGLT2 inhibitors to remogliflozin. Change in the parameters after 6 months, you can see HbA1c like reduction of 0.1 to 0.119, means they are maintained, right? The efficacy is maintained even with remogliflozin. Fasting glucose as well as the postprandial glucose reduction was continued. Weight reduction of 0.8 to plus or minus 0.2. Body mass index was also reduced. Like for example, in this study, if the patient was on canagliflozin, if he is not affordable and not able to continue that medication, those patients were put on remogliflozin and given an option. In that, when they did that, the efficacy was continued with the remogliflozin. Another study, that is the reduced microalbuminuria observed in the individual patients. You can see here in this study, in patients with microalbuminuria randomized to remo or metformin, significant reduction in albuminuria was seen compared to the placebo. This is one important article. Another one, comparable reduction versus canagliflozin. So comparative study of Remo 100 milligrams versus Cana 300 milligrams at 12 weeks, you can see that HbA1c reduction was seen about 1.96, fasting plasma glucose reduction of 47.9, postprandial reduction of 49.8, and weight reduction about 1.38 kgs. Next, another study, Remogliflozin in Indian type 2 diabetes, a real world study. You can see the real world effectiveness after 6 months of treatment. HbA1c reduction was 1.3, fasting glucose of 17.2 reduction, postprandial of 56.4 milligrams reduction, weight reduction of 4.2 kgs. This was published in ADA 8-year scientific virtual conference. So, inspired study, the summary, if you see, does it corroborate with your routine practice? That is always the question. So, in a real world clinical settings, Remo-based regimens demonstrated significant reduction of glycemic parameters, that is HbA1c of 0.95, fasting plasma glucose of 42.4, postprandial glucose of 69.1. Non-glycemic parameters like weight, body weight reduction of 2.6, systolic blood pressure reduction of 3.3, diastolic blood pressure of 2.3. So the bottom line, you can see the reduction in HbA1c, fasting glucose and postprandial glucose was higher in case of higher baseline HbA1c. The reduction of body weight was higher in case of higher baseline body mass index. So, in the real world clinical settings, Remo based regime demonstrated the therapy was observed to be safe and tolerable. The genitourinary tract infection being the most common. The impact on renal parameters was not clinically significant. Remo therapy showed favorable results in terms of reduced uric acid level and USCR in a routine clinical practice. The results observed was comparable to glycemic efficacy observed in real world studies of other SGLT2 inhibitors. So, ladies and gentlemen, conclusion of my talk today is Remogliflozin had been demonstrated to be efficacious and safety in the type 2 diabetes management in phase 3 clinical trial. Inspire study has demonstrated Remo to provide effective improvement in both glycemic and non-glycemic parameters with no major safety concerns. With equivalent reduction, Remogliflozin provide more cost-effective solution for type 2 diabetes management requiring SGLT2 inhibitors therapy. In my personal experience, I should say I am using Remogliflozin extensively in my practice. What I have seen is the acceptance in our patients is very good. Means they, because of the cost factor, they accept it very easily. And if you educate the patient about the hygiene factors regarding the genital urinary hygiene, the side effect profile of urinary tract infection and mycotic infections are less observed. Even if it is seen in few of the patient, it is very easily treatable. Only what I've seen is in one or two patient, I've seen the unexplained weakness starting on this molecule, but we were forced to stop. Apart from that, there is no major concern. So in my when I compared with the Cana, Dapa, and Empagliflozin as well, the outcome with Remogliflozin is very, very good. And what I have seen in my practice also, when the patient on the combination of Remo with the DPP4 inhibitors, the genital urinary tract infection is also less, like especially the mycotic infection. Probably DPP4 inhibitors have a role to play in inhibiting the fungal enzymes. So the mycotic infection is also very less. But acceptance is good. Only thing is maybe like you have to give it twice a day because of the shorter half-life. But even then, if you compare to the cost of the available SGLT2 inhibitor, this is very much affordable to our patients, and they easily accept, and the result outcome is also good. And the further future looks very good with Remogliflozin. I'm sure all of you are aware. Yesterday, they have launched this combination of Remogliflozin with Vildagliptin combination. I think it will be one of the blockbuster combination because if the cost is affordable, if you use it as a BD dosage of Remo and Vildagliptin combination, I'm sure you are getting a very good result in our patient. I'm sure because as you are aware, the vildagliptin cost was reduced. Now the dapagliflozin cost is also reduced. So there will be a tough competition with Remo and Dapa. At this point of time, if you are getting a molecule that is remogliflozin with vildagliptin combination at a affordable rate, definitely all of us will very happy to use in our patient. And definitely the outcome of the like outcome studies, like we have seen the inspired study and pivotal study as I discussed today, that it is showing a more positive response in our patient. Like earlier we used to feel like when the Canada used had come in the picture because of the cost factor, though we know that this many of our patients were benefited with this molecule, but because of the cost constraint we were tied up and we were unable to write this molecule and give the benefit to our patient. Now this the remogliflozin showing the efficacious with the both the national study like 6 month study is there, and it has been compared with dapagliflozin, which is very important, and we have seen the efficacy is good. So definitely we can use very comfortably in our patient. So thank you for your patience hearing. If you have any questions, kindly post it, we can answer. Over to Dr. Srinivas.
Thank you, Dr. Arvinda. It was a very nice, elaborate lecture. So now we have seen the world of diabetes has seen an entire world have seen in the management of diabetes from a simple control of blood sugars to a beyond this control of blood sugars in the form of so much pleiotropic effects of drugs, which has beautifully enlightened. Dr. Arvinda showed what are all the effects of other SGLT inhibitors, which are playing a huge role in the management of diabetes. So now other questions regarding this SGLT inhibitors, role in diabetes, where exactly they can be used at. We'll take the questions at the end of all the sessions. Now I would like to request Dr. Raghuram sir to take sessions from here. I would like to request sir to introduce the next speaker. Sir.
Thank you, Srinivas. Good evening to one and all. At the outset, I thank the organizers, the Frontiers Diabetes Awareness and Research Society, especially Dr. Faraz, who was our beloved student. And also I'm happy to be here when one of the my student, Dr. Chandra Mohan, is also my student, and he was talking on the urinary tract infection management. He was the managing director, consultant urologist, Preeti Urology and Kidney Center, Honorary Secretary, IMA, Kukatpalli chapter, and first person to introduce the RIRS laser treatment, I think, and focus on pediatric RIRS laparoscopy, and conducted international national workshops, and recently published bilateral simultaneous on anuria in a 4-month male baby and nephrolithotomy in a 9 months infant, and published prospective randomized studies, variable laser setting for better management, International Journal of Clinical Urology, presented a video on our technique of retrograde internal surgery in less than 5 years old children at third annual AU Congress 2018 in Copenhagen, Denmark. And now he is going to talk on the urinary tract infection, which is very common. As a previous speaker said that especially when the SGLT2 inhibitors are using, there are little probably more prevalent urinary tract infection. And now Dr. Chandramohan is going to talk on how best we can treat the urinary tract infection and its management. Over to Dr. Chandramohan.
Sir, thank you very much. Raghuram sir, my teacher at the Usmania Medical College. At the outset, I thank Frontiers Diabetes Awareness and Research Society, Gurukul, for giving this opportunity. Particularly Dr. Faraj, thank you for your initiation. Yesterday only I came to know this. Very nice that such type of academic activities. I'm very happy to be one of the speakers today. And I, along with the co-speakers, Dr. Srinivas and Arvind and Dr. Amit Gupta, Dr. Srinivas, I know when I was in Yashoda also. With this brief, this thing, I will start my presentation. I have allocated 20 minutes of time on urinary tract infection disease and management. As I am the surgeon, slightly I will have tendency to go a little bit on the why it happens, how it can be detected, than going into the too much on antibiotic naturally. So definitely UTI is an inflammatory response of the urothelium to bacterial invasion. Bacteriuria and pyuria is the manifestation. It's a huge topic, bacteriuria. 10 to the power of 3 colony forming units per ml is the definition, and pyuria is more than 10. But every patient, diabetic, old age, pregnancy, child, has to be seen separately. No uniform rules. Common in women, this I want to focus because day in and day out, we see many of the women roaming with a lot of files, lot of antibiotics, lot of IV antibiotics, still pus cells are there, they get depressed. 50% of the women get UTI. 1 in every 3 women, at least 1 episode of UTI by the age of 25 years, recurrent UTI 20 to 40%. Shorter length of the female urethra, proximity to the anus. I want to spend 3 minutes of time here, an important point. The main focus is on the fecal bacteria. The woman who has recurrent urinary tract infection source is from the fecal bacteria. That means the fecal bacteria contaminate the vagina. From the vagina, it goes into the bladder. So the primary prevention is contamination of the fecal bacteria into the vagina. How? 90% of the Indians do toilet habit with water washing. That water washing contamination of the vagina and then having sexual intercourse later on is the commonest in the middle age. Whereas in diabetic and postmenopausal women, it is because of the lack of immunity of the vaginal wall. Culprit is the contamination from the fecal bacteria. This is very important. So males, UTI is not common, has to be taken seriously, except elderly male with diabetic. It may be common, that is also to be taken seriously. Girls and boys, very seriously you have to take. Even 1 episode of infection in boy has to undergo MCUG, micturating cystourethrogram, to rule out reflux. Whereas incidence of UTI in elderly is markedly increased because as the elderly population is increased. 21% of women and 12% of men over 65 years of age as severe bacteriuria, normal also. Routes of infection, systemic routes of infection, commonly seen by physicians in the ICU ventilators where multiple sources of infection are there. But for us, urologists and nephrologists, primarily is the retrograde from the vagina, whereas in men, because of the BPH and sexual activity. So pathogenesis, you all know there is no point going. It is the wall. It is the wall of the bladder urothelium, which is protective. Every 6 weeks, 1 layer completely goes and a new layer comes. But during infection, in 6 hours, it will be denuded. That means it's a raw surface. The moment raw surface is formed, all these symptoms happen. How much raw surface, how much is the bacterial load will decide whether it spreads up towards the kidney, leading to pyelonephritis, which makes it a complicated UTI. So most UTI in women are who are healthy. Interaction occurs between virulence and host defense. Women who has urinary tract infection has some amount of defense mechanism lost. So urinary tract in host defense mechanism, acidic, this is all theory, but it's important. You have to maintain acidic pH. That's why majority of the people apply the estrogen creams as well as the acidic creams in the vagina to maintain the lactobacillus, the environment. High urine osmolality urine inhibitors in bacterial adherence, competitive inhibitors, mechanical flushing, even the protection. If you pass more number of times urine, the bacteria will go out by drinking more water. This is a basic principle. Everybody says you take coconut water like that. Partly true. Whereas urothelial secretion of cytokines, chemokines, mucopolysaccharide lining, IgA, in men prostatic secretion which contain zinc also is helpful. So other things are genetic, biological, behavioral, and others. Simple depression can cause UTI in females. The commonest behavioral problems are sexual intercourse, diaphragms, spermicides, and antimicrobial. Liberally, if you use antimicrobial, some people use amikacin. It's not correct. The source of infection is fecal bacteria. Tomorrow again the feces will be there. Feces cannot be without bacteria. There is no point giving simple asymptomatic treating with amikacin, even if it is Streptococcus, E. coli, Proteus, unless it is Pseudomonas. Now, pregnancy, menopause, chronic health conditions, sexual activity, birth control, personal hygiene are all very important. Somebody who is not at all caring about the underwears or the wetness or the toilet habits, then especially in old females, when they get debilitated, if you examine them, fecal matter will be there all in the vagina. So naturally, which antibiotic will treat that? Loads of bacteria will be there in the vagina. No point treating with any antibiotic. So from our point of view, if somebody is an intermittent catheterization, if somebody has a neurogenic component, for example, high pressure bladder, diabetic atonic bladder, all these things will make even one invasion. I will tell you, simple catheterization for normal knee joint replacement can produce bacteriuria in diabetic and can be devastating. You have to take all the precautions. Number load is more, infection is more. Again, same colonization in the vagina, urothelial penetration, ascent to the kidney, pyelonephritis, and acute kidney injury leading to the raised creatinine. Then coming to the symptoms, which is very common: dysuria, frequency, hematuria, suprapubic tenderness, chills and rigors. Last one is flank pain. Flank pains and fever, not a good, very common in diabetic women. Has to be treated seriously like complicated infections. Back pain, again, chills and rigors, nausea, vomiting indicate severity, whereas lower back pain, just blood in urine, frequent painful urination, particularly in a newly married couple, is not at all serious. There is no need to do cystoscopy for them. There is no need to give IV antibiotic for them. One doses or 5 days single doses of the ciprofloxacin may be sufficient, which does not produce much or nitrofurantoin, because it's called honeymoon cystitis. Whereas urethritis is very, very common. Anybody might have faced. So nothing. Bacteria is important. Documentation is important. Sending urine culture is important. That too, not in all. In young females, not necessary. Only complete urine examination is okay. But if you are getting recurrent, you have to send urine culture. You all know that Pseudomonas versus E. coli, Pseudomonas is dangerous, especially if you have any other problem like anatomical abnormality, stone, or the reflux like that. These are theory slide for the microbiologist, how it looks like. People say that all the clinicians should know how to see the urine examination, but present day era, the subspecialties have come. You have to be in touch with them. You have to be in touch with this type of webinars, at least to get updated. If not, you are seeing the urine microscopy. I have not seen, but if you keep on listening webinars like this, like whatever Frontier Diabetes is doing, well, very good. Even I have shared this link all of a sudden 1 hour back with all the physicians I know, so that they will also get updated. Community acquired UTI is not at all a problem. Nosocomial is anytime can resistant infection can occur. Uncomplicated is women, healthy women. Complicated UTI, there can be a big list. Anything other than women is a complicated. Take it for granted. So concept of uncomplicated and complicated is how severe. Once it goes into the kidney and ureter, it is complicated. You have to be careful. So again, theory slide: uncomplicated, complicated, recurrent, catheter-associated urosepsis. Most important is recurrent UTI with a frequency of at least 3 UTIs per year or 2 UTIs in the last 6 months. Many of them fall in that. Inadequate treatment, lack of resistance, and source of infection is not removed. Inadequate treatment, lack of the resistance, and source of the infection not removed. These three. Otherwise, everybody knows how to treat urosepsis. Urosepsis is one of the commonest cause of mortality and morbidity in private sector ICUs. Predisposing factors. Age, naturally, anybody who is aged will get infections. Diabetes is the main, spinal cord injury, pediatric patient, and catheterization. Long-term catheterization is very common. Any old person who is leaking in the house, they take only one thing, either a pad or catheter. That catheter, every patient who is normal patient also, at the 7th day will get the UTI. Investigations, naturally we do CBP, culture sensitivity, collect the urine specimen, urine dipstick, microscopy, ultrasound, and CT. What is practical? Complete urine examination, urine culture in a normal patient. If any patient who is abnormal, ultrasound abdomen. These three. I don't want to go into the details. The only detail I want to go is that how do you collect in children? Suprapubic aspiration is the best. How do you correct in women? Midstream is correct. How do you collect in men? Midstream is correct. How do you collect in a catheter patient? That is difficult. So you have to put needle in the column of the new bag which is kept, aspirate and take it. That will not have contaminant. That too after changing the bag next day. So 4 points. Suprapubic aspiration in children, midstream by the men, midstream by the women, and catheterized patient change the bag next day. Whatever the column you have in the bag, aspirate and send it. Sometimes it is difficult how to wash before taking the sample. No washing, nothing, water or soap, nothing else. Just midstream. Only thing is that private part should not be touched with the bottle. Otherwise, contaminant will come. 90% of the staphylococcus is contaminant. Don't treat unnecessarily, especially in women and men. Men staphylococcus, 99% contaminated in our experience, except very old people. This is the collection point. That appearance of the urine is slightly important, because I remember people like Raghuram sir, Raghunandan sir, Ram Reddy sir, who is some of the teachers are not there. They focus on the basics. Even I am telling, being a busy practitioner, sometimes we don't look into it. This slide is important. Cloudy urine, bacterial urine infection. Red and cloudy, schistosomias bacterial. Brown and cloudy, black water fever. Yellow-brown, acute viral hepatitis, obstructive jaundice. Yellow-orange, hemolysis. Milky white, filariasis or chyluria. So these things are very, very important, and we cannot ignore these basics. Now coming to the antibacterial, for all practical purposes, we are not using trimethoprim sulfamethoxyl commonly. We are. I hope the physicians accept this. We are using number 1 ciprofloxacin, number 2 cefuroxime oxetil, number 3 nitrofurantoin. These three do not produce resistance as much, among which ciprofloxacin and nitrofurantoin are better for simple infections. Once it is complicated, culture, not much discussion. This is the way we talk. Physicians will go into the depth, but for us surgeons, culture is the most important thing. So acute pyelonephritis cannot be taken easily. So numerous WBC Brownian movement will be there. These are the pictures how the ultrasound looks like. It is very easy. If you are doing daily ultrasound, you can easily pick out enlarged kidney with a lot of CMD. It will be like a thick, it will be like a large kidney. We see opposite side, there will be a line of CMD, whereas here CMD will not be there. That is a very, very classical picture. Never touch that kidney by stenting or PCNL like that. For us, practical purposes, give antibiotics, give time. If they are not responding, repeat the ultrasound. Now CT findings is classical like this. The CMD is lost, the enlarged kidney, focal bacterial nephritis obstruction. This all comes with experience. If you are keep on seeing the CT, when you see the opposite side, beautiful, nice, glossy kidney will be there. This side, irregular, patchy kidney will be there. Now coming to the management to the APN, urine culture. If the fever is not there, fluoroquinolones is very good. If the fever is there, admit, drain abscess, treat with antibiotics. The difference between surgeon and physician is we treat for 3-4 days and neglect. When you work with a nephrologist or good physician, you will come to know that 7 to 14 days is must, depending on the clinical condition. One more important is, do not forget fungal infections. In diabetic patients. Now, EA guidelines, first line treatment, ciprofloxacin, cefotaxime, levofloxacin. Second line is piperacillin tazobactam. Third line is imipenem. We go to imipenem only in certain level of patients, whereas physicians go because they have to treat more number of patients with multiple problems. Doses, I don't want to go in detail. This is a theory. Everybody knows that these dosages. Staging of gas involvement of the kidney, which is more with us like urologists. Once the gas is there, it's not good. If you see one fruit which is smelling in the house, means you cannot eat it. That means more the gas, more the damage. So there are various gradations. This Hong and Seng classification of EPN, EPN with gas, emphysematous pyelonephritis is with multiple pockets, destroyed kidney, people die. Even I am telling, even if they survive, within 6 months, 1 year, chances of getting MI, chances of getting any other comorbidities is very high. Keep that in mind. Now, EPN, gas in EPN. Severe necrotizing parenchymal infection is one aspect. Gas is CO2 produced by alcoholic fermentation of glucose. So these gas forming bacteria are very, very fast in growing and destroy the parenchyma. And usually they will have sepsis and they come with hypotension. Aggressive management with vasopressins like noradrenaline is very, very important. Noradrenaline for us in perioperative period is life-saving. Early noradrenaline, early antibiotics, culture. If you have not done culture, you will burn your finger. So this is the algorithm. If you have no parenchyma, nephrectomy. If it is not responding to the antibiotics, nephrectomy. Special groups like chronic renal failure, bilateral renal disease, solitary kidney, you have to be very careful. If you think that the kidney removal will save the life, even in worst situation with ventilator, remove the kidney. Or else put a needle, or else put a drain, or else put a stent, but don't wait with antibiotic. Gas means drain. It is like abscess. So this is the same EAU guidelines regarding the antibiotics. So again, same urinary tract infection, type 2 diabetes. You people are more experienced as physicians. Same protocols apply. Only thing is that bit of pus cells, we will have deviation. More than 10 to the power of 5 will be changed to more than 10 to the power of 2. If you are in catheter, if you are in long-term involving catheter, more than 10 to the power of 3, like that it will be divided. Otherwise, rest of the theme is same. Same asymptomatic acute cystitis, everything is same, and treatment is also same. Most important is if you do not control the sugar, again it will come. Second two, if the resistance is less, that means patient is deteriorating over a period of long time. He or she has to improve the immunity as well as properly go with the multi-system department. All the departments, cardiologist, physician, good physician who can treat all the parts like a peripheral neuropathy, eye, everything has to be taken care. Thank you very much. Without teamwork, it is not possible. We, the 7 urologists of the Preeti Urology and Kidney Hospital, with 2 hospitals already working and 3rd hospital coming up in Gachibowli, we look forward with the academic activities like this. Thank you, Dr. Faraj, for giving this opportunity. Thank you all the Frontiers Diabetes Awareness and Research Society for giving this opportunity.
Thank you, Chandramohan, for an excellent presentation covering all the aspects, high risk group and the clinical features, and what precautions we have to take while investigating the, collecting the samples and the management. You have done excellent thing. Anyway, we are, and there may be a lot of questions at the end. We'll discuss in the panel discussion. And next, shall we move on to the next speaker? Next topic. And next topic is the COVID and diabetic management by Dr. Amit Gupta. And this pandemic, there is a lot of difficulties, a lot of variations, and while under the at home and a patient admitted in the hospital, very tough time to control the diabetes. Now, Dr. Amit Gupta is going to discuss a lot regarding how best we can manage the diabetes. And he was the director in the multi-specialty hospital, Greater Noida, and director of the Center for Diabetes Care, Greater Noida, and the AAC, Diabetes Resource Center Committee member, and the immediate past communication director, American Diabetes Association 2018 and 20, and Apex body member, and governing body member, Uttar Pradesh Diabetic Association, Health Disease State Network, Lipid in News Subcontinent, and Diabetes Awareness Initiative Award, Diabetes India, great thing, and Padmakar Tripathi Young Scientist Award in 2017. So he is a well experienced and a good orator. Now he is I'm handing over mic to Gupta to start his presentation.
Thank you very much, sir, for such a kind introduction. And it is a privilege for me to be introduced by such a senior professor and person who has taught my colleagues and my friends. Thank you very much, sir. With your permission, sir, I would like to share my screen. At the outset, sir, I would like to also thank Dr. Faraz Farishta for making part of this important program, Gurukul. His concept is very, very good, and I know he is working very hard for management of diabetes and all. I will just, sir, just give me a couple of minutes before I start sharing my screen, sir. Just a second. Is my screen visible to you, sir? Is my screen visible to you, sir? Now?
Yeah. Yes, ma'am.
Yes.
Full screen.
Okay. So let me start. As we know that we are in the middle of a pandemic, we can, as Dr. Arvinda said very nicely, now we are living in a time where we are talking about after Corona or before Corona. Now we don't know whether we are in BC or AC or we are in the middle of the Corona. And the coronavirus has impacted, there is not a single person who has not been impacted by this virus all across the world. So we all know that diabetes management, I'm not going into the details of the diabetes management, but there are certain key aspects which we need to keep in our mind whenever we are dealing with patients with diabetes who contract corona. Or now there are cases also where after coronavirus infections, the patients, they develop diabetes. So we have to be careful both the ways. As we know, the COVID-19 and diabetes, COVID-19 obviously has a higher mortality and complication rates. As you can see very clearly, that the mortality rate in patients who don't have diabetes is somewhere around 2.7%. However, in the presence of the diabetes, the mortality rate rises up to 7.8%. So it is almost 3 times more in persons who are living with diabetes than those without diabetes. Patients with diabetes and COVID, they require more medical interventions, and they had significant higher mortality, as already explained, and they had higher rates of multiple organ injury. So the people with diabetes are susceptible to greater complications of the COVID-19 infection. This is a very, very common question, and what we know so far, a patient would come and ask us, am I more likely to get COVID-19 because I have diabetes? Or if I get COVID-19, am I likely to have more complications because I have diabetes? So the answer is that diabetes does not seem to increase the risk of contracting COVID-19. But however, when a person living with diabetes develops COVID-19, they are more likely to suffer from severe disease. So this is a one drawback of having diabetes and COVID-19 together. So as we see, COVID-19 and diabetes mellitus, there is an unholy interaction of the two pandemics. If you see the patients with diabetes, they have poor immunity. There is already raised inflammatory cytokines and markers. They're down-regulated ACE2 levels. We are using ACE inhibitors and ARBs in these patients. COVID-19 can lead to beta cell damage. It again can increase the insulin resistance. This electrolytemia like hypokalemia is very common in these patients. Most of the patients, they receive corticosteroids and some other drugs like remdesivir nowadays. And we need to see whether the use of corticosteroids in these patients who may be using them for a long period can also lead to a new incident diabetes. So actually COVID-19 is fueling diabetes, and diabetes mellitus is increasing the complication of the COVID-19. So who is at more risk from the coronavirus? It is not just the diabetes, the person who are having cardiovascular disease, person with chronic respiratory disease, people with hypertension, cancer. These are also the other causes which increases the risk of coronavirus infection or the COVID-19 infection. So what are the benefits of good glucose control? So whenever we are maintaining good glucose control, there is better outcomes during hospitalization. And vigilance with glucose control, we have to be vigilant with the glucose control even after discharge. It is because post-COVID complications are very common. And the hyperglycemia as a complication of post-COVID infection is a very, very common thing which has been seen now. And when we observe these patients, it improves longer term outcomes and reduced mortality. Nowadays, there is a new thing. People are talking about the use of CGM devices in hospital, which can also improve outcomes as well in these patients. There are studies regarding that also. As we all know that the clinical picture of the COVID-19 and the mortality of the COVID-19, which we have already discussed, and this is the clinical picture of COVID-19, which is typically, we know that people, they get infected. Some of them, they develop symptoms. And out of this, very few people will get hospitalized. And out of those who get hospitalized, about 5% of the patient, they will require ICU hospitalization, and 2.7% is the mortality rate. So I would just like to take you through certain guidelines, then I will take you through the Indian guidelines as well. So these are the consensus recommendation for the COVID-19 and metabolic disease. These are published in the Lancet in April and later revised. So when it comes to outpatient care of diabetes patients, so we want to prevent the infections in patients with diabetes. So we want to sensitize them that what is the importance of optimal metabolic control. We want to optimize the current therapy. So those who are not infected and we are seeing them in outpatients as a outpatient, we want to sensitize them against the COVID-19 infection. We want to sensitize that they have to achieve a good glycemic control. We want to tell them that they have to be, they should not discontinue any kind of treatment they are taking. They should continue with their treatment, and they can utilize telemedicine and the other connected health models if possible to maintain contact with their healthcare providers. When we have the inpatients or intensive care units, we have to monitor the COVID-19 patients for the development of the new onset diabetes. So we need to monitor their blood sugar levels. And those patients who are already having diabetes and infected and in the ICU, they have to be monitored closely for the ketones. They have to be monitored closely for the electrolytes. And we have to use the insulin in these patients because the insulin is the likely drug which can improve the glycemic control in these patients. The target aims, when we want to, what are the targets that remains the same? We want to keep the fasting, we want to keep the blood glucose in the compartment of 70 to 180 mg/%. We want to keep an HbA1c less than 7%. There is no different target. Against the time in range target and the CGM targets are the same, that we want to keep them more than 70% of the time in range. And we want to minimize the risk of hypoglycemia in these patients. So whenever we are treating these patients, we need to keep these things in mind, that we want to minimize hypoglycemia. We don't want the patient to have too much fluctuations in the blood sugar. And the HbA1c and the blood glucose targets, they remain the same as with the as before. When it comes to drugs, choosing a drugs in patients with type 2 diabetes or any type of diabetes, we need to remember that metformin, as we know that one of the side effects of the metformin is that it can lead to lactic acidosis in some cases, and dehydration can also happen. So dehydration and lactic acidosis, if patients are already dehydrated, then the chances of this can increase. So if a patient, we know that COVID-19 is also associated with acute kidney injuries. So we have to be very careful when you are using metformin in patients infected with COVID-19. SGLT2 inhibitors, again, there are Remogliflozin, as Dr. Aravinda has already talked about. The other three is Cana, Dapa, and Dapagliflozin, we know that. And the risk of, again, the risk of dehydration and euglycemic ketoacidosis, as we know, is sometimes exists with these agents. So we should be cautious while using these agents, and patients should avoid initiating therapy during respiratory illness. So any person who comes to us has respiratory symptoms along with diabetes, we should be avoiding the initiation of SGLT2 inhibitors till the time the respiratory, the acute illness subsides. And we should also monitor renal functions closely, because we had to follow the eGFR cutoffs whenever we are prescribing the SGLT2 inhibitors. The drugs like GLP-1 agonist, as we know that there are many which are available now. And again, but this has this actually reduces the appetite. This can actually make the patient this actually can increase certain other symptoms like nausea, vomiting, abdominal pain. So this is not an ideal drug to start when a person is suffering from diabetes. DPP-4 inhibitors, these drugs are generally well tolerated. They do not cause too much adverse events, and there are certain reports and studies as well that use of DPP-4 inhibitors in some those patients who are already on DPP-4 inhibitors, somehow the DPP-4 inhibition is protective against coronavirus. So though there are conflicting reports, but such reports are also there. Insulin, any person who is taking insulin therapy should not be stopped. Whenever a person is on insulin therapy having coronavirus infection, regular self-monitoring of blood glucose should be recommended. Person, if it is possible, person should be checking the blood sugar 4 to 6 times a day. And we have to adjust the therapy carefully so that there are no additional risk of hypoglycemia. So these are certain special considerations which we have already discussed. And ACE has also given some position statement. ACE in the March 18 and 2020, they said that recent studies have shown that those hospitalized for severe disease, 22.2 to 26.9% reported living with diabetes. So almost 1/4 of the hospitalized population is persons suffering from diabetes. Diabetes and high glucose levels are again associated with increased complications, respiratory failure, and mortality in patients hospitalized with COVID-19. So because people with diabetes may also have other comorbidities such as organ failure and cardiovascular disease, it is very important to follow specific COVID-19 precautions and prevention guidance from any organization which we are following. Similar statements has been given by various other organizations, and these are other guidance for our patients that we should tell them they should have adequate lot of the medications with them. They should have provision for monitoring self-monitoring of blood glucose. They should also have a BP instrument at home, and if possible, then a pulse oximeter at home will also help them in monitoring if any such situation arises. IDF again has given certain guidelines. IDF says that older people and people with pre-existing medical conditions, including diabetes, they are more vulnerable to becoming severely ill with the COVID-19 virus. So that we have already seen. So many organizations, they are all coming with the same kind of guidance when it comes to coronavirus. Our RSSDI, which is one of the largest organizations of the diabetes professionals in Asia, and it is doing wonderful work for the patient education as well as for the physician education, diabetologist education. They have also come up with certain guidance. This guidance document is available on the website of RSSDI, so you can access it in detail. And again, it highlights the fact that we have to be very careful about choosing a drug. We have to be very careful when it comes to managing the therapy in these patients. So this guidance details of these guidance can be accessed at the RSSDI website itself. This is something which I would like to discuss a little bit in detail. There is clinical guidance on diabetes management at COVID-19 patient management facility. So this is also given by the Ministry of Health and Family Welfare, and this is the government guidance, so we should be aware about this guidance as well. What are the important points in these guidelines is that every patient should be screened at admission for hyperglycemia with at least 2 capillary blood glucose values, one pre-meal and one post-meal. So any patient with or without history of diabetes admitted in the COVID-19 facility must be tested for the presence of hyperglycemia, and two tests are recommended. Every patient with diabetes should be started on a diet which is modified for diabetes, and they advise that kindly ensure that patients strictly adhere to the timing and quantity advised in the diet chart. So this is one of the important points which has been highlighted. They have given a scenario. So ensure all newly admitted patients are evaluated for diabetes and hyperglycemia. One, we have checked that, and we have found that the pre-meal sugar and the post-meal sugar are less than 140 and less than 180. Then we advise them healthy diet, no need for further monitoring in these patients, and we send the fasting plasma glucose and HbA1c to the lab next day. However, if the pre-meal sugar is more than 140 and the post-meal sugar is more than 180, then we advise multiple time testing in the day, before breakfast, before lunch, before dinner, and after dinner. Fasting BP, fasting sugar and the HbA1c is again sent to the lab next day. And if the patient is admitted with any value more than 200 milligram deciliter with some osmotic symptoms, again we send the fasting plasma glucose and HbA1c to the lab. If pre-meal sugar is less than 140 to 150, post-meal 180 to 200, the diabetic diet is advised. However, if the values are more than that, along with the diabetic diet, we initiate oral anti-diabetic agents and insulin as per the protocol. So this is a clear guidance which has been given by the Ministry of Health and Family Welfare, and I think the entire document can be accessed on the site of the Ministry of Health and Family Welfare. So treatment option when it comes to patients with known diabetes who are already in oral anti-diabetic drugs at admission, we can continue existing OADs if all of the below mentioned criteria are fulfilled. Blood glucose levels are controlled, patient is conscious, oriented, and has good oral acceptance. The COVID symptoms of the patients are mild and the kidney function test and the liver function test are normal. So if the patient is having normal kidney function, normal liver functions, the symptoms are mild, the consciousness and the orientation is normal, has good oral intake, and blood glucose is well controlled, so we can continue with all kinds of OAD, whatever the patient is taking. However, if the patient does not fulfill all of the above criteria, we have to consult a doctor, treating physician, and we have to start the patient on a basal bolus insulin regime, which is also, we know that, multiple subcutaneous insulin injection regime or intravenous insulin infusion, depending on the blood glucose levels. So to initiate OAD in patients newly detected to have diabetes at admission, if the patient, as we have already told, if the blood glucose levels are 150 to 180 and the post meal it is 200 to 250, then we initiate oral anti-diabetic drugs. Government advises that we can initiate the patient on metformin again. A gliptin, vildagliptin, sitagliptin, or linagliptin, or even tenligliptin has been mentioned in the document. They can all be started, providing patient meets the criteria. And the criteria is that the pre-meal sugar, that is the fasting sugar, is between 150 to 180, and the post-meal sugar is less than 250. And other criteria in the sections which we have mentioned, that there is normal kidney function, normal liver function, normal patient is conscious oriented, and mild symptoms, then we can initiate these oral anti-diabetic drugs. Otherwise, the ministry mentions that we have to initiate the patient on the insulin. So I will not be going into the detail of how to initiate a basal bolus insulin regime. I know all of you are very well versed with that, and all of you are using that, but we just wanted to mention the guidelines. So I will just skip that part. Again, the guidance says that if the patient is on OAD and the blood glucose levels are again uncontrolled, then again we have to put the patient on a insulin therapy. I would just like to mention the effectiveness of telemedicine in diabetes care. We should be using diabetes care. We should be using telemedicine in diabetes care wherever it is possible, because it limits face-to-face exposure. It provides personal connection with the patients. It allows for data monitoring and review. It allows for the adjustment of the treatment. And it also gives us an opportunity for more patient education, and it gives patients more control over their disease. So rather than not having patients consulting anybody, it is better to consult them on telemedicine platform. We all know that challenges of telemedicine are that obtaining current data is not always possible. Patient may struggle with technology, not possible to conduct physical exam, patient responsible for reporting weight, BP, and support staff is not easily integrated into the care, and the primary clinician the responsibility of the clinician increases. Strategies for overcoming telemedicine challenges are that we can have support staff which can call patients in advance of clinical appointment to help with data download and answer basic questions. We can provide some kind of hands-on training to help patients use their devices, upload data, and use their phones, tablet, or computer for virtual appointments. And additional patient technology education may be needed, and we can use technology to review data with patients, which we are doing regularly at our center. So telemedicine in diabetes is likely to remain even in the future as well. And just for your knowledge, that recently central government has also started a telemedicine facility for senior citizens. So all senior citizens who are advised by the government that they should not go out in the corona pandemic, they can take telemedicine facility, they can avail the telemedicine facility from the government of India. So these are certain key points which I would like to again highlight before I conclude. People with diabetes developing COVID-19, they are at increased risk for complications and mortality. We should emphasize adherence to the healthy diet and lifestyle. And as we know, access to the healthcare is limited by the infection control measures in the community, such as lockdown, sometimes self-isolation in the quarantine. General precautions to prevent COVID-19 should again be re-emphasized, and they are critical for people with diabetes and their families. Patients with multiple comorbidities need extra caution. Continuation of good dietary practices, safe physical activities, and regular glucose monitoring should be encouraged. Measures such as telemedicine services and drug dispensing for extended duration or by home delivery should be adopted to reduce exposure of diabetes patients while ensuring uninterrupted continuity of care. People with diabetes who develop COVID-19 should continue their routine medications unless the illness is severe. For severe COVID-19 in diabetes patients, glycemic control is best achieved with insulin. SGLT inhibitors are best discontinued until the illness is mild. ACE inhibitors and AR should ARB should be continued unless contraindications develop or further evidence emerges against their use. Individualized decisions should be taken on continuing aspirin and statins. And research into pharmacological therapies for treatment and prevention of COVID-19 in people with diabetes is what is urgently needed. So with that, I would like to conclude and again thank Dr. Faraj Farishta for giving me this opportunity to present this talk in front of all of you. Thank you very much.
Thank you, Amit Gupta, for excellent presentation covering all the events of the COVID infection during the type 2 diabetes. And now there may be a lot of queries from the audience. And shall we start with the panel discussion? Srinivas?
Yes, sir. First, can we have Mintu? Can you just show us any questions from the audience?
I'll put it up in the chat, sir. I'm just checking it now.
So I would like to add one thing, Dr. Amit Gupta, for the excellent presentation. Dr. Faraj, you would like to add something?
I think right from the first presentation, I think SGL2 is definitely changing the way we are treating our diabetic patients. And most of the guidelines now do say that, yes, SGL2 is the drug of choice for patients with pre-existing hospitalization for heart failure or patients who had chronic kidney disease. So this is one class of drug which is definitely helping in the pipe, pump, and filters. Coming to the next one, I think, yes, very well discussed. So I would not be able to tell much on the urinary tract infections part. But coming to SGL2 and UTIs, I think whenever we are starting patients on SGL2, we are telling them to maintain personal hygiene, take more amount of water, and certain basic precautions so that there is a reduction in infections. And well said by Dr. Amit. I think over to you and Dr. Agramlu, sir. You can take it ahead from here.
Yeah, to just add to what Dr. Amit ji has told, what we have seen at our hospital these days in last couple of months or in last 6 months, we have done a study in all the patients, the COVID patients who got admitted to our hospital. We have seen what is the percentage of the patients who are diabetic, who are pre-diabetic, who are overdue diabetic. So our study told that more than 95% of the patients who got admitted with moderate to severe disease are all diabetics with a high uncontrolled sugars. And HbA1c, what we have seen in data, all the patients who got sicker admitted to ICU, their HbA1c was more than 8.5. Who got a mild to moderate illness, their HbA1c was more than 7 to 8.5. And all the patients who were just with a milder illness, surprisingly, even their sugars are also rising after a smaller dose of steroids. They were all in pre-diabetic. So we have not seen a single person who is neither a pre-diabetic nor a diabetic. So this all what the data we have seen is the entire brunt of this COVID illness was predominantly on the patients with a pre-diabetic or a diabetic. And the sicker patients are all diabetic with uncontrolled sugars or multiple drugs, and HbA1c was more than 8.5. And all the patients where HbA1c was more than 10 with other comorbid illness were those category of patients who became very much sicker, and those patients went into a cytokine storm, and the mortality was very much higher in those category of patients. So this COVID illness has shown that the brunt of disease was much higher in those patients, the pre-diabetic, diabetic, and diabetic with uncontrolled sugars. And this disease has brought out so much amount of people with a hidden diabetes, a latent diabetes. So much people have came to know that they are either diabetes or pre-diabetes because of this illness.
I must appreciate Dr. Srinivas that you are not only dealing with corona patients, you are also investing your time and energy in research as well, which is going to benefit the medical fraternity very much. I must appreciate your efforts. And your study is really an eye-opener, and actually it throws light on what kind of patients they are getting sicker and going to the ICUs and all. So I think diabetes is really a very, very serious factor. So what other risk factors did you find in these patients apart from the diabetes? Are there other factors as well?
Yeah. The other factors were cardiovascular disease. The other co-factor which has led the more amount of mortality in patients was a cardiovascular disease, and the much higher mortality was seen in those patients with a renal disease. So majority of the patients whom we lost were all the renal disease patients, diabetic patients, diabetic nephropathy, AK and CKD are the sector of the patients which we lost. So majority of the mortality was in that sector of the patients. The diabetic with no renal involvement, either nephropathy, we could save them or salvage them. And other sector where the patients apart from the diabetic nephropathy was the cardiac patients. So coronary artery disease, either a single vessel, two vessel disease or past history of CABG, or other sector of patients after nephropathy who are at a higher risk. But unanimously, one single factor was the high sugars, higher HbA1c, or in the pre-diabetic patients with a single dose of steroids, when the sugars were rising more than 300, that was giving us a clue that probably this patient might go into moderate or severe or might require an ICU support. That was the thing. That's the reason we have made sure that what you have told very nicely, that pre-meal and post-meal blood sugars in every patient who got admitted, and we made it mandatory to check HbA1c in every patient. The reason was, suppose when we are trying to send the patient at the time of discharge with the steroids for another couple of weeks, so we wanted to see whether the patient was a diabetic or a pre-diabetic. So we wanted to know whether that person at the time of discharge with some amount of small dose of steroids will need any form of therapy for the diabetes management. So as per HbA1c, we used to leave the patient that this is a pre-diabetic patient or this person is a diabetes de novo patient and is requiring for steroids in a couple of weeks. We used to adjust the medications in the diabetes management either in a simpler methods like a gliptins, as I rightly said, or else taking the help of basal insulin or basal bolus if the sugars are higher with the amount of steroid which he was taking. And what you said was very, very right, that we have not used any form of the drugs like metformins and sulfonylureas. Why? Because the appetite, the intake was very much not to say the same in every patient, because so many factors are there, GI illness and their appetite factors. So the only drugs which we used are the gliptins with a very less negligible risk of hypoglycemias like sitagliptin, vildagliptin and all. The other best therapy was a basal insulin. So these were the two forms of therapies which were used predominantly in all these months in all our patients who were discharged with a pre-diabetic or a diabetic or uncontrolled diabetes.
Very good, sir. Excellent, sir.
Amit, I want some. See, everybody says that the diabetic patients are the mortality, morbidity high with the COVID infection. Is it only the glycemic status that leading to this mortality, or because of other comorbidities leads to more of morbidity and mortality?
Sir, glycemic uncontrolled poor glycemia actually adds to the mortality. But it is difficult to say that it is the single factor, because we also see patients, there must be patients with Dr. Srinivas as well, who had severe diabetes, uncontrolled diabetes, but they recovered well. They may not have experienced that kind of complications. So this is the unpredictability which we are seeing with the COVID. There is a added risk with diabetes, but the COVID-19 doesn't know. I don't think the virus identifies any person on the basis of risk factors alone, because we have seen young patients coming to the COVID-19 as well. We have seen patients recovering at the age of 95 with all kinds of comorbidities from the COVID-19. I think what determines the mortality in COVID-19 is the lung involvement. So it is the lung involvement and the ultimate oxygen requirement, which is what kind of patient goes through the all kind of management. So it is the lung involvement, I think, that plays the deciding factor. Because with normal X-rays, there are many findings that we find that CT is showing many consolidations and many patches and all. And now, for the last few months, what we are seeing is that since our hospital is a non-COVID hospital, the patient has a COVID-19 antigen RT-PCR report at the 5th day or 6th day of the illness. And the report keeps coming negative again and again. But the classical signs, classical symptoms, classical radiological manifestations, rise in other biomarkers, they are all like same. So this kind of patients are also on rise.
Sir, briskly, I would like to share experience like what I fully agree with Dr. Amit. So frankly speaking, we still don't know which patient is going to get infected, which patient is going to come out, which patient is going home safely. I can share you one experience. Elderly male, 65 or 66 years old, diabetic patients, COVID. He got admitted. He stayed with us for 47 days. He developed a severe lung injury, went on to ventilator. He developed acute myocardial infarction, did stenting. He developed acute stroke. He developed renal insufficiency. We did dialysis. Surprisingly, after day 46, he walked away. And another
problem
have seen same patients were succumbing, a younger patient was succumbing. So we never know even till date we never know who is going to come out. But as Raghuram sir was asking, like whether the diabetes hyperglycemia is predominant factor, yeah, partly, sir, because of hyperglycemia, and when you're using the drugs, predominantly steroids, life-saving drugs, the sugars were higher. Majority of the patients where we have seen the opportunistic infections like bacterial infections, and Dr. Chandramohan was clearly telling the urinary tract infections, especially after SGL2, there was so much amount of bacterial infections and much more of fungal infections, even at the time of after discharge because of the steroids. So there are multifactorial which is causing all this mortality, not only apart from this blood sugars, sir.
Dr. Arvinda sir, we are giving quite one long while, and we don't want you to keep quiet. You are the superstar. Enlighten us with some of your valuable inputs, sir.
Nothing, Amit, as you rightly pointed out, like Corona is one thing which till now many of us or many of the doctors all across the globe are not able to understand the exact situation. But the basic concept in the management of Corona is apart from the regular precautions, the any patients admitted in the hospital or symptomatic should be given utmost importance in managing the other comorbidities, especially when it comes to diabetes, when it comes to hypertension or heart disease. All that has to be simultaneously monitored, because what we are seeing generally is many patients coming across saying, doctor, suddenly he was admitted like 2 hours before and he died. So they think because of corona the patient has died, but because of the COVID-19 it is died. It may not be the true sometimes, because the associated comorbid conditions like it might have precipitated the cardiac events. It might have some sepsis factors may be there. So which we are not able to identify or explain to our patients. Many have the question like how long, like how did the patient die, why the things happened so early. So all these things are a triggering factor. So till the vaccine come, I think we should keep our finger crossed and treat every patient as a potential serious patient only. So we should not be complacent, and we should be very aggressive from the mode of management, giving importance to all the parameters. And of course, our diabetes management is an important thing, because as all of us know, because of the sugars are very high, there is a chances of reduced immunity, and the recovery rate is very less. Especially, we know the steroids plays an important role in the management of diabetes, in management of corona. So they are prone to see the elevation in blood sugar. So appropriate management of diabetes manager, as you rightly pointed out in your presentation, Amit, about the basal bolus initiation and controlling the diabetes plays an important role. So once the recovery rate is there, the post-COVID explanation also has to be given to our patients. Many of our patients, as a normal tendency, they think, oh, okay, once COVID is over, they got a resistance, they got an antibody, and they think they are free, and they never wear mask, and they go flamboyant in the city, roaming around like that. It is happening actually. So education about that factors is also very important, like because post-COVID complications are occurring, like especially with regarding to the lung ailments. There are so many things which is happening. So we have to be keep educating them about these factors, tell them about the importance of still wearing mask and still not to be complacent. All these factors is very crucial. But as the things are looking positive in the coming weeks, I should say, we should earlier we used to tell coming months. At least now we can say that coming weeks, looks very positive, and the vaccines are going to come, I'm sure. So, which will be, especially in India, the economical vaccine, though the Pfizer vaccine may not be very suitable because it is stored under -70. I'm not sure how it will be useful in our country, but other vaccines, especially maybe Oxford vaccine or the Serum Institute, what they are conducting the studies, they are showing the positive result. More than 90%, any vaccine efficacy is reasonably good. I personally feel that. So if it is a one shot or a two shot at a prescribed intervals, we need to be taken care, given to our patient. But till then, till the vaccines are practically available, practically come into the picture, we need to be completely careful, whether we are in Bangalore, Delhi, Noida, or Hyderabad. All over India, the situation is the same. So we have to take care of ourselves as well as our family, as well as our patients as well. So that's what I can say, Amit.
Very right, sir.
Amit, as you rightly mentioned, people like us after 65, 70 years old, and telemedicine is very only the way we can have a treatment. But is there any legal problems with the telemedicine? Because sometimes people, I mean, especially clinicians, for PUO, sometimes we don't do the physical examination, we miss some of the like a lymph nodes and somewhere else, but all the investigation being done and nothing has been came out, but it's not responding to the antibiotic, and sometimes such things may happen. So, is there any legal measures we can take care of not to have such problems?
You have asked a very important question, but about the experience of last few months, what we have learned is that, and telemedicine is going to stay, but it is not for somebody who is acutely sick. So if somebody is having is acutely sick, then we should be writing and referring the patient to the hospital. One important thing which we need to remember is that we have to ensure that we are consulting the right person. So we have to identify the ID of the patient. So sometimes there may be people who may just phone up, book a consult, and they may not be the right person who you are consulting, and they may misuse your document. So we have to be very sure that who we are consulting. So this is one important thing. Second important legal aspect is that we need to keep the records with us for next 3 years. So whatever we are prescribing, we have to keep the records with us. As far as limitation of the physical examination is concerned, so I think, sir, it is implied. We, as a doctor also knows that on teleconsultation platform, he cannot examine the patient. The patient also knows that since I'm doing a teleconsult, doctor cannot examine me. So whatever data I am providing, so from that point of view, you are safe. I don't think there is any problem with that, because it is an implied thing. We know that nothing can happen on the physical part, and it is a limited consultation. So that is implied. But if there is an emergency, somebody is having chest pain, that we cannot write a prescription. We have to ask the patient to go to hospital and attend the emergency. We have to verify the ID, and whatever we write or whatever we write, we need to keep a record of that, so that if in future anything arises, then we are able to produce the document at least.
Chandra Mohan, can you?
Yes, sir. Yes, sir.
Suppose if a diabetic patient comes to us and they ask most of the time what general advice to the entire family to prevent this episodes of urinary tract infection, because urinary tract infections are even with or without diabetes in female, as you said, it is very common because of the proximity.
Sir, in female we give a set of advices, where practical advice in the OPD I give is: number one, pass urine within 5 minutes of passing in the same bathroom, re-empty the bladder. There is nothing harm. Just wait for 1 minute, so that bladder will get trained for that extra urine to expel. Otherwise, they will get slowly post-void residual urine filling up. Number two, don't use any water to clean the private parts. Use the tissue paper. That contaminates, and already bacteria on the fecal flora as well as the undergarments will add multiplication to that wet environment. This is the second advice. Third advice is blood sugar control. There is no doubt you all do that. And fourth advice, night after 5 o'clock, we advise to take less water, because Slowly what happens 60, 70, 80, their capacities will increase from 500 to 800, particularly in Indian population where they don't want to go to bathrooms. During travel also they withhold. Every child, girl child, to the up to the adult and late old female, they have habit of retaining the urine. These four are detrimental to them because the bacteria multiply. That is from my point of view, sir.
And Dr. Ravinder,
Yes, sir.
all the pleiotropic actions of the SGLT drugs are related to the classic effect, or is there any specific benefit with the Remogliflozin?
Most of the things here, like if you see the various data, sir, it looks like a class effect only. Minor differences here and there you can observe, like if some beneficial with like 0.1 to 0.12 reduction in HbA1c, or 2 to 4 millimeters reduction in systolic blood pressure, weight reduction of 3 to 4 kgs. You may see here and there the same thing. One have the plus point, another have the negative point. But if you take the pleiotropic effect as an SGLT2 inhibitor, it looks like a class effect, because it is one of the drugs which has got multiple effects, especially when it comes to diabetes. The various studies, if you go through with all the SGLT2 inhibitors, they say that especially diabetes with atherosclerotic cardiovascular disease, or as well as heart failure, if you see the effect on the not only diabetes, as a cardiovascular drug also, it looks very beneficial. So it is one of the drug at the moment to be prescribed to all our diabetes after metformin. But personally, I feel like that. But only thing is, cost factor was a major hindrance to our patients. Now the cost being very economical, this is one of the second line agent. Like earlier, we used to say because of the economic problem, we used to think of sulfonylureas only. Now the thing has changed. Now the thing is changing, because we have Remogliflozin, now Dapa is also there. Now Remo is coming with Vildagliptin with an economical price. All these are a positive trend, especially for our Indian patients.
So, sir, I would just like to ask one thing from Dr. Arvinda, sir. So, Remogliflozin is just a poor man's gliflozin, or sir, is it more than that?
It's like like if you see Amit, when teneligliptin came, they say poor man's gliptin is teneligliptin. But unfortunately, teneligliptin did not have major studies, if you see very closely. But here we have a poor man gliflozin only as Remogliflozin. But the thing is, we have a good scientific data, like comparative data is also there. That is the important thing. It has been compared with Dapagliflozin. It has been compared with the Canagliflozin, and data are available. So the poor man gliflozin with a good scientific backup. I should say that.
Thank you, sir.
I hope all the speakers have done excellent work, excellent presentation. Extremely happy, and if as the time is, the next sessions are going on, and as time is short, then we can. I thank all the speakers for their excellent presentation, and we'll hand over the session to the organizer.
Thank you, sir. Thank you. Thank you.
Yeah, on behalf of our FTRS Gurukul program, I like to thank Dr. Amit Gupta, Dr. Arvinda, Dr. Chandra Mohan for giving time in the Academy of Medical Educations and sharing their experiences. Thank you all once again, and thank you to my sir, respected sir Raghuramani sir, and very happy to see you. Share the screen with you, sir.
Yeah, thank you everyone. Thank you all my colleagues and friends, and then thank you so much, sir, for making it so lively. And of course, thank you all the postgraduates and our junior and our fellow colleagues as well, and hope you had a good time. Please join us tomorrow again at 7 o'clock for lively discussion on type 1 diabetes, the crux in management, and management of thyroid in pregnancy. Thank you so much.
Bye for us. Bye, Srinivas.
Thank you.
Bye.
Thank you
Bye,
very much for the
Jagdish.
opportunity.
Thank you.
Bye, Chandra.